Welcome everybody to day 4 of our CCRN exam prep class, and today we're going to be talking about neurological. So in this I'm going to start with cerebral blood flow and then move on to the types of disruptions in that flow. So we'll talk about occlusive and hemorrhagic strokes, as well as cerebral perfusion issues, trauma, seizures, and we'll end with meningitis. Alright, so neuro is a fairly large part of the exam, about 7% or 14 questions. And we'll start off with cerebral blood flow. So when learning neurotrauma, which is what we deal with, we want to start by understanding the anatomy of the cerebral arterial and venous blood flow, because that's where so a lot of our problems lie. So, and I got an image here, a couple images here that show the two types of arterial flow. So we have our carotid arterial flow that's going to supply the front and top half of our brain. And then we have our vertebral flow, and that's going to supply our cerebellum and back, lower portion of our brain. It's interesting, most people have a dominant left or right carotid artery. Most people are dominant in their left carotid artery. And people can have different dominant vertebral arteries. So what they can do is, it might not necessarily be pertinent to your patient, but it might be what causes some of these strokes, is if people have differing neuroanatomy. If they have a weaker vessel or if they have a stronger flow in a certain vessel, that could explain why they potentially hemorrhaged. So this arterial flow is going to come up from the carotids and it's going to split off into the main artery we're looking at with strokes, and that's the middle cerebral artery, the MCA. You've probably seen this when you have a patient that comes in with a stroke and they neurosurgeon or neurologist will name the stroke as MCA1, MCA2. And if you see this image on the top left, that's what it's kind of explaining here. It's going to start as an MCA1 segment, and then as you start to extend from the carotid artery, you're going to get your M2, M3 segment. And if you remember in a nursing school when we talked about the homunculus, wherever that clot or hemorrhage ends up happening in this MCA is where you're going to see your deficits. So if this happens a lot further in the M segment, say down deep in the M3 segment, then you'll still have a lot of potential function. Whereas if it were to happen in the MCA1 or M1 segment, you'd probably see a lot of deficits. So these images just show kind of what different arteries stem off and what they supply. So when you start to see those strokes coming in, then you know, if you know your brain structures, you know what's affected, and that would kind of direct your assessment. So the next thing we can talk about is cerebral spinal fluid flow. And you can see it's made in two areas. It's made in the choroid plexus in the midbrain, or in the middle of the brain, and down near the cerebellum. And this is going to flow based on respiratory force and cardiac pulsation. Kind of flows almost like blood in your calves. It's kind of just pushed, not necessarily squeezed by its own vessels. So what's going to happen is this will filter and supply the brain with other types of nutrients. It's CSF has a lot of water, neurotransmitters, different ions, glucose, proteins. And so it's going to come up to your arachnoid space, and that's where it kind of filters out, almost like a glomerulus in the kidney. And then that's what enters your venous system. So that's how the CSF is almost filtered. And then you can see your venous flow. It's a lot of these sinuses that drain down into your jugular veins and out of your head. All right, so when we start to see disruptions in this blood flow, we got to consider them as either occlusions So that's our ischemic injuries. Within the vessel, hemorrhages, so either ischemic to hemorrhagic conversions or aneurysm ruptures, or exterior vessel masses, so AV malformations, that are kind of redirecting blood flow. Those could also become hemorrhagic. Trauma, so that's going to end up with swelling. Tumors can compress vessels, and then just a generalized elevated ICP from like encephalopathy. So for the priority of these suspected occlusive disruptions, we need to determine if it's gone hemorrhagic. That's the big reason why we take CTs, CTAs, MRIs, is if we're going to correct this occlusive injury, we need to make sure that it's not a hemorrhagic injury as well. So we'll obtain a CT to exclude hemorrhage. If we would be able to see a large white segment in the CT if there was bleeding. CTA, CT angiography, is used to rule out these larger vessel occlusions. So what you'll end up seeing is occlusion in the MCA1, the internal carotid artery, the basilar artery, or the vertebral artery. And so that'll help direct more so if we need to do a thrombectomy. If it's more distal in any of those four arteries, then the risk versus reward of a thrombectomy is not always certain. CT perfusion or an MRI can also determine where an occlusion is and to what extent the damage is caused. If you do a program called ENLS, it'll kind of explain a lot of why they do the MRIs and how they're looking at this idea of a mismatch ratio. The idea is that we're looking of where the core ischemic damage is, the stuff that's not savable, the tissue that's already dead, and then we're looking at this idea of a penumbra, this tissue that could potentially be saved if we resolve the issue soon enough. And if that ratio results in a state where the patient would have considerable amount of recovery, then they may go ahead and try to rescue that clot. So I'm sure we've all seen this idea of exclusion and inclusion factors for a thrombectomy, or for TPA. And there's a lot of exclusion criteria, a lot of things related to trauma, any kind of bleeding, any kind of previous surgery. So you can look through this, pause it, look through all of these. You've probably seen a list like this before when going through some sort of nursing orientation. And there's only a few inclusion criteria. You have to be old enough. You have to have a negative CT, meaning you don't have a bleed, and it has to be soon enough. It has to be within 3 hours, typically, is what hospitals like to go for. We allow for permissive hypertension. That's why that elevated blood pressure above that is so high, because we want to try to perfuse collaterally with a high blood pressure. So by having a high blood pressure, it'll kind of push through those collateral arteries and allow the blood to get to these underperfused areas from the direction it would normally go. TPA is given as a 0.9 milligram per kilogram dose, and roughly 10% of that is given as a bolus before it's infused over time. One big thing you see with occlusive strokes is this term known as homonymous hemaniopia, and that's blindness in the contralateral side from the injury, so contralateral opposite side. So if you have injury to the left side of your brain from an occlusive stroke, and your vision centers are no longer being perfused, then as you can see on this image to the right, those nerves are going to no longer supply the left side of the eye. And because the eye is like a mirror, you'll lose vision on the right side of the eye. Another kind of reflex we look for is a Babinski reflex. And that's on the opposite side because as our nerves go down our head, they cross over each other and they operate the opposite side. So you end up getting a Babinski reflex on the right side if you were to have a left-sided stroke. Then something that we don't talk about as much, but that is something to consider in your assessment, is when you have a stroke on the right side, you have more disturbed spatial awareness and more emotional flatness. But we have the Broca area, the speaking area on our left side of the brain. So when we have left-sided strokes, we end up seeing more aphasia. And then, as we all know, you have a lot more muscle weakness on the opposite side of the injury. And this also includes, and they'll try to test you on this, is muscles that move the eye. So if we lose muscular function on the opposite side of our injury, let's say we have a left-sided injury, we'll lose the right-sided muscles of our eye. And so the left-sided muscles will be strong and pull the eye to the left. So what they like to say is you'll look towards the boo-boo. You'll look towards the injury. In the case of a pontine stroke, that's your, as you can see here, if you zoom in and look at these pontine arteries coming off the basilar artery, they're 90 degrees off the basilar artery, so it's very easy for things to get stuck. And if you have a pontine stroke, it's a regulator of the medulla oblongata. So the pons is going to take these breathing signals and it's going to kind of smooth them out, make them more consistent. So when we have damage to that, you start to see this apneustic breathing. It's a term to describe an excessively deep breath in and then an insufficient exhalation. So you have a very short exhalation after a big deep breath in. So you start to retain a lot of CO2. Other things you see with strokes is, especially with pontine strokes, is pinpoint pupils. And I'm going to go through how pupillary change works in the next couple slides. So here's this idea again of how nerves cross over in the midbrain. And something you can see with hemorrhagic stroke specifically is posturing. When you start to have pressure applied to the brain, you start to initially see decorticate posturing. So that's when the patient's arms are drawn up into their core. It might not be as obvious as the pictures that depict decorticate posturing look like. So you might want to just keep an idea of, how bad their posturing is. If it's just slightly, it might still indicate brain swelling. Then as you get pushed further down into the medulla from the swelling, you start to see decerebral posturing. That's when your arms extend out. Okay, so then as we start to see swelling, we've kind of moved into hemorrhagic disruptions in blood flow. This is, let's say, a ischemic event gone hemorrhagic, or a potential trauma. You start to have brain swelling. And what it does is it starts to push these structures inward into the middle because your ventricles are open spaces that can be compressed. Okay, The brain has nowhere to go, so it tries to squish and close off potential open areas. So the blood up here is squishing this ventricle closed. And as it does that, it's going to start to compress the nerve in the midbrain. That's the highest part of the brainstem. It's going to compress parts of that midbrain that control eye constriction. Right? The parasympathetic, that's your rest and digest nervous system. Anytime you're in that, your eyes will constrict. That's what controls your constriction. Versus sympathetic, a sympathetic response, you would want your eyes very dilated so you can take as much information in. Right? Just think about when you've seen a cat look at something that it's chasing. Its eyes get very wide. So in the case of a hemorrhagic stroke, it's going to first compress those parasympathetic nerves that control eye constriction. So what you'll see is the side of the injury that's bleeding. So let's say it's on the left side, you're having this brain bleed. Then you would expect your left eye to be more dilated. Okay? Because we've cut off that parasympathetic nervous system. We've cut off the constriction. So now all we have left is dilation. And so when this idea of pushing blood inward, pushing the brain inward, it's known as an uncal herniation. It's a lateral compression of the brain, causes dilation of the pupil. Ipsilateral is one side. And then as this bleed gets worse, we call it supratentorial herniation. This little plate in between the top portion of your brain and your cerebellum is known as the tentorium. So when we have supratentorial herniation, that's pushing both of these parasympathetic nerves, we'll have bilaterally dilated pupils, which is very dangerous. Once we've seen that, we know that we have extreme brain swelling, extreme ICP, and that we're going to start to see Cushing's triad, which we'll talk about. Something to keep an eye on is you're always going to see a change in level of consciousness first. See, a lot of your brain, your normal brain functions, your normal awareness centers are located higher than your midbrain pons and medulla, so you'll start to see that first, and then you'll start to see pupillary change later. So the big things that are dangerous with any kind of hemorrhagic disruption of blood flow is the idea of them rebleeding. If they've become stable and they've clotted off and they're not bleeding anymore, then that's great. So what we need to be watching for in a patient with a history of bleeding is the idea of rebleeding and avoiding vasospasms. Specifically with subarachnoid hemorrhages, patients are very likely to have another rebleeding incident. And so you'll see these typically elderly patients with Alzheimer's will come in and have a subarachnoid hemorrhage, small. They may have had some in the past, and they're going to be there for roughly a week to make sure that this doesn't happen again. And a lot of this blood could cause irritation to the vascular wall and cause the vessel to actually spasm, vasospasm. And so we can give medications to avoid that. Because as those vessels spasm, no blood flow is going through them. So it can cause more ischemia. Something they do in the neuro ICU is this idea of cranial Dopplers to monitor for vasospasms right before they happen. But regardless, we give nimodipine as a calcium channel blocker to try to avoid that constriction effect of a vasospasm. Anything that could cause a vasospasm, like hypovolemia, is it can be a problem too. Anytime you have low volume in a vessel, it's going to trigger it to spasm. So we want to promote hypervolemia. We want to try to dilute the blood. And again, the idea of going back to permissive hypertension, allowing blood flow to go to different areas of the brain. Some other things related to hemorrhagic disruption that you might see on the exam include an arteriovenous malformation, something that's usually grows from birth or in early childhood. You'll never really see this occur in an adult later in life. This will be something that's gone unnoticed. But if you were to have a brain scan now and not have an AVM, you never would develop an AVM. So what ends up happening is this cluster of blood vessels eventually gets weakened, or enough pressure from hypertension applies to it and it bursts. And the first thing we'll usually see is a seizure. That blood on the meningeal surface of the brain will cause a seizure. So surgery is usually a curative. If we can see this early in life, or at some point in life incidentally, then we'll cut it out. We'll go in surgically if it's not too deep and try to cut it out to prevent the incidence of ever happening. Embolization may help by just preventing it from bursting until we can go into surgery. But embolization isn't always the answer. So as far as the exam goes, just remember that surgery, prepping the patient for surgery, will potentially be the answer. Or if they have bled, then it's getting them to surgery to repair the bleed. Okay, so this idea of Cushing's triad, we've probably all have heard it before, but I'll go through so we remember the direction things go. It's always hard to remember in the moment when your patient's herniating. Is it high heart rate, low heart rate? Is it wide pulse pressure, narrow pulse pressure? Is it fast breathing, slow breathing? So knowing the signs and why they happen is how you'll remember better. Knowing why something happens will stick in your brain a lot better than just remembering high or low symptoms. So initially, when the brain starts to increase in pressure, we see that pressure overcome the mean arterial pressure. And so what ends up happening is that vessel is not strong enough, doesn't have enough outward pressure to overcome the inward pressure. So the vessel will compress. As it starts to do this, the sympathetic innervation is going to recognize that, and it's going to cause systemic arteries to be constricted to try to restore that cerebral perfusion. We've lost that perfusion because it's been compressed by this bleed or this mass. And so the sympathetic system responds by increasing systolic blood pressure. So it's going to release neurotransmitters to increase blood pressure, like epinephrine, norepinephrine. And by doing that, it's going to not only increase the blood pressure, but also increase the heart rate initially. And so that epinephrine release is going to increase the blood pressure. It's going to increase the heart rate. The heart is going to sense that in the aortic arch, this raise in blood pressure, and trigger a compensatory response of parasympathetic innervation to lower the heart rate. So big things you see right off the bat with a very high ICP is a high systemic blood pressure, systolic blood pressure, and a compensatory bradycardia. Okay. Sometimes the vagus nerve may also be compressed or distorted, causing even a worsening bradycardia. So high systolic blood pressure from the epinephrine trying to overcome that ICP, and then a bradycardia to respond, systemic response to hypertension. Now, if we start to go back to the idea of supratentorial herniation, if the brain starts getting pressed downwards onto the pons and medulla, a lot of that involuntary breathing goes away. And so we start to see normal rhythmic respirations. So we start to see very arrhythmic respirations. So arrhythmic respiration, high systolic blood pressure at a compensatory bradycardia. The way you calculate MAP is not systolic minus diastolic pressure. It's not just what's in between. It's actually diastolic pressure plus the third of the difference between the two. So you'll take the difference between the two, systolic and diastolic, cut that into a third, and add that to your diastolic pressure, and that's your mean average pressure. Now, we can't have anything go significantly over that as far as our ICP goes. So our cerebral perfusion pressure, what's required to perfuse our brain, should be between 80 and 100, and you can calculate that by taking your MAP and subtracting your intracranial pressure. So normally the perfusion pressure is between 80 and 100, and then the minimum to perfuse the brain is 50. At the minimum amount of pressure required to perfuse the brain is 50. And once you're below that, that's when you start to see the Cushing's triad come into play, because we're trying to reperfuse the brain with Cushing's triad. So let's say your MAP is 60 and your ICP is 10. Well, then you have right there your minimum perfusion pressure of your brain. Now, the normal ICP of us just walking around is very low. It's probably around 5 or less. And in your neuro patients, it might be higher. Now, anything above 20, and now this is similar with intra-abdominal pressure, is anything greater than 20 for a sustained amount of time. You know, if they cough and their pressure rises up to 21, 22, but then goes back down, that doesn't necessarily count as highly concerning. But if it's sustained above 20, then that's where we start to see our cerebral perfusion pressure not being 50 or greater. So some things we can do to correct this, Decadron over other steroids is commonly used to help reduce the swelling of the brain. But here's what you're going to see on your monitor when you're monitoring ICP through a EVD. We don't typically use bolts anymore because it doesn't have the ability to actually treat the pressure, just monitor the pressure. So bolts have kind of gone on the wayside. But in your ICP waveform, you're going to have 3 waves. You're going to have your first wave is a P1, that's your arterial pulsation. So you're going to see a wave of pressure come into your monitor, and that's going to be the initial arterial pulsation through your brain. And then as the brain kind of reflects that shock, that's when you see your cerebral compliance, your P2. Now this wave should never be above P1, because what that tells you is that the brain isn't compliant. Like when we talked about lung compliance and the respiratory section, which I think is day 5, we'll talk about this idea of compliance as well. So you always want your P2, that second wave, to show the rebounding shock as lower than our actual arterial pulsation. And then finally, your P3, that third wave, is when the aortic valve closes and you receive another shock wave of pressure from that closing, that back pressure of blood hitting that aortic valve. That's when you get your P3. So you have those 1, 2, 3 waves. You'll see those if you have a good waveform on your EVD. And then you'll take that average pressure, and that'll give you your ICP. So if you see this image on the right, the C kind of shows a normal or high pressure of around 15 here. You kind of take the middle. And then as your brain starts to lose more and more compliance, you can see how this P2 wave gets higher and higher. And as that happens, so too does your ICP. So you can see somewhat normal ICP, at least below 20. The P waves below that P1. Then as you start to get higher and higher intracranial pressures, you start to lose compliance with your P2. So they may ask you a question on the exam. On the patient's ICP monitor, P2 starts to show higher than the P1. What might this indicate? It might have the answer of, loss of intracranial compliance or increased ICP. A great way to review this kind of stuff and EVDs is Critical Care Fast Facts has a small little blue book. It can fit in your scrub pocket. And they have a great neuro section that talks all about this stuff that I would totally recommend. If you can't get it before your exam, then definitely get it after, because it'll definitely help you in taking care of your neuro patients when you get them. So this is kind of describing a little bit more what these different A, B, and C waves are. You won't need to know this for the exam, but if you love neuro and you want to learn more about the plateau waves, and go ahead, pause it here, or look that up on your own time. So what do we do to lower the intracranial pressure? What do we do to lower it to the point where we don't lose our cerebral perfusion pressure? Well, the big thing we're trying to do is avoid any kind of secondary brain injury, anything that's going to cause another shock to the system, just like we would in cardiac. And those things are hypotension, so those could potentially cause vasospasms and rebleeding, any hypoxemia, or any drop in that cerebral perfusion pressure, so MAP. One thing we'll do is often administer fluids. So we'll often administer like a 3% fluid. And this can help avoid seizures as well. So we want to try to maintain euvolemia, because the patient obviously won't be drinking. So we want to maintain their euvolemia and avoid any kind of sudden drops in sodium. We want to try to maximize and optimize the amount of blood flow up to the brain. And we can do that by positioning the neck in a very midline upright position. So making sure that their neck isn't all crooked, that's potentially cutting off or disturbing that blood flow up to the brain and out of the brain. Other things we can do is anything we can do to decrease the amount of oxygen demand on the brain itself. So when we have all those bright lights on and the patient's staring up into the sun that we can turn down, then why not turn that down, right? So turn the lights off, reduce any discomfort. If they're laying on wires or crooked in bed, try to fix that as much as possible. And as much as it is hard to kind of communicate with the family, we really want to minimize how much they're stimulating the patient. And this is easier to do when you first interact with the family. And remember, there's a lot of questions on the exam that are not just straightforward, like complex nursing topics. A lot of the questions on the exam you're going to see are family interactions and patient interactions. So one of the things you could do is try to educate the family early on how important oxygen demand on the brain is. In a very layman's term, explaining that the more we're doing to them, the more that they have to use their oxygen in their brain, which isn't helping it heal. And so they'll understand that, and they'll really try to be present in the room, but not be a hindrance to their recovery. And if the patient's family's gone and they don't request anything in particular, shutting off the TV, minimizing any stimulation on the ears, minimizing suctioning. Obviously, if they're intubated and we need that, then we have to do it. But that, as well as coughing, can increase the intracranial pressure. It can worsen a bleed if they have a bleed. And then we really want to promote sedation as much as neuro providers want to keep it all off and monitor for worsening condition. We really want to, propofol could really help with oxygen demand on the brain. All right, so what are some other things we can do to lower that ICP? One of these is controversial and has been recommended against, but some hospitals still use it and they may still bring it up on the exam, so it's good to know about, and that's hyperventilation, this idea of hyperventilation. Now, most people will agree and say that this should not be used anymore, and I'll explain why. So, a reduced partial pressure of arterial CO2. So once you watch the respiratory lecture, I'll talk more about partial pressure. A reduced CO2, which can occur easily through hyperventilation, right? You're blowing off CO2, incites vasoconstriction in the cerebral arterioles. So by blowing off CO2, you can temporarily vasoconstrict the cerebral arterioles. So what happens is you reduce the blood flow to the brain, you reduce the ICP, but at a cost, you expose that tissue to more ischemia, right? So we're lowering the ICP in an acute state where ICP is, let's say, sustained at like 30, and the patient's potentially herniating. You can hyperventilate to try to reduce that ICP, but you're really causing a lot of tissue ischemia, which is going to further the deficits that you'll see in that patient. And from some articles I read, what they recommend is that you monitor transcutaneous CO2, which is something we really don't do. I actually have never heard of this until I read some articles about hospitals that were doing that, where they monitor CO2 based on the jugular vein. So, as far as testing purposes go, they'll probably recommend against hyperventilation because of that ischemia issue. Some other things that can cause a change in ICP or indirect changes to the ICP can be temperature. So for every 1 degree increase in Celsius of your temperature, you could expect a rise in the PaCO2. And once we said there was a rise, we said that there is dilation. when there's a decrease in CO2, there's constriction. So the higher your patient's temperature is, potentially more dilated your cerebral vasculature is, which is not necessarily a good thing. So this is why, one of the reasons why we try to control neurotemping when that neurological balances of thermal regulation are out of sync, and you have large fluctuations in temperature. This could be one of the reasons why we try to control it. All right, so we'll move on from occlusive and hemorrhagic blood flow problems to more traumatic brain injuries. So these are some of the injuries that they can ask you on the exam. One of them being epidural bleeds. So there we talked about there's subarachnoid hemorrhages, which we'll cover. There's epidural bleeds. There's subdural bleeds. So epidural bleeds occur most commonly in the temporal bone, as there's sagittal sutures there, your suture lines that run along there, and it's one of the weaker parts of the skull. And of course, in one of the weakest parts of your skull, there's a very important artery, your meningeal artery, that runs along that suture line. So what you can get is head trauma on that suture line, especially when you're young and you're more reckless. And what you end up getting is a sudden headache, vomiting. And in this case, because the bleeding is lower along that temporal line, you can sometimes see pupillary changes before level of consciousness changes, right? We talked about where that parasympathetic innervation for our pupils comes from, and our consciousness centers are above that. So if you're having a shift lower in your brain laterally, then you could potentially see pupillary change first. So that's a big thing that they can ask about on the test is you see pupillary change first, the patient's still conscious, they're vomiting, have a sudden headache, and you'd suggest that they potentially have an epidural bleed. And one of the common things they'll do is instead of managing ICP, they'll actually just burr a hole into where they believe that bleed is after imaging and release the pressure. Now this is different in subdural bleeds, subarachnoid hemorrhages as well, as they won't always go after these bleeds. Subarachnoids especially can occur in more elderly patients. That's the weaker vasculature. One thing that happens in Alzheimer's is you get these amyloid precursor proteins, and it'll start to break down the vasculature of the brain. They'll also destroy some connections, which is where you see a lot of the symptoms of Alzheimer's. And so what ends up happening is you get these burst weak vessels because of the severity of the disease. So very similar symptoms with epidural bleeds, sudden onset of a headache, worst headache of your life. We'll call it a thunderclap headache. But they won't always go and surgically evacuate unless it's significant enough. And usually when it's significant enough, it's hemodynamically significant. So if it's just painful, it's one of the worst things I've seen in working in the ICU is patients with subarachnoid and subdural bleeds. Are just because you really don't want to promote sedation in these patients. You want to monitor for changes in bleeding. And like we talked about with that rebleeding within that 4 to 8 day window, as these patients are just sitting there in excruciating pain for a week, and there's not much you can do about it. So it's sad, but it's definitely there's reasons behind why we do certain treatment. Okay, some other little smaller things that they discuss on the exam and that they'll give you as far as trauma goes is the different types of skull fractures. And what you're looking for in with these is do they repair them or do they leave them to heal on their own? So basilar skull fracture is lower at the base of the skull, right? We talked about basilar circulation coming off the vertebral circulation, which supplies the back and bottom half of the brain. Linear skull fracture does not require surgery as often, but where you start to see the need for surgical intervention is when you have depressed or open skull fractures. Anything that's contaminated that could lead to meningitis or some sort of infection. Anything with a dural tear or a large hematoma underneath, and anything with a depression of over 5 millimeters. This is a big thing that they ask: is the depression significant enough to have to go repair it? Comminuted is very similar to open in that there's fragmentation, and then diastatic can be just along a suture line. So just some different terminology to be aware of. Basilar skull fractures are significant, but they don't always very rarely need surgical repair. It's that linear fracture at the base of the skull, a lot of seen in motor vehicle accidents when you have that coup, counter coup movement. This sudden movement ends up fracturing that weak bone. And what you'll see is the meningeal blood, right? We talked about that meningeal artery being on the bottom part of the skull. That blood starts to seep into the arachnoid villi, the CSF, and cranial sinuses. So it'll pool at the front of the head, underneath your eyelids, and around your eyes. And you'll start to see you can look up pictures. They look like they have raccoon eyes. So that's that. And then you can get something called battle sign, named after the last name of the man who found it. And that's mastoid ecchymosis. So mastoid bone, you'll see some pooling of the blood there. And you could sometimes see pooling around the ears as well. So you'll also see otorrhea, so you can sometimes have tears in that layer of CSF, and or causing CSF to leak out. So you can get otorrhea, and then you can have rhinorrhea, where you have CSF leaking running from the nose. And the big thing that they're going to quiz you on with this idea of a basilar skull fracture is what do you do when you start to see CSF? How do you identify that it is CSF? And then the importance of making sure that nothing is inserted up into the nose, that it's covered and not packed. You don't want to be packing the nose with any kind of gauze. You just want to lightly place gauze underneath the nares to catch it, but not allow the patient to kind of mess with their nose at all and blow their nose. That's where you're going to get trauma and worsening changes. So because it's not a big, large displaced fracture, there's no need to surgically intervene. You can heal on its own. But because there's openings into the CSF, into the brain, there's a much higher likelihood of developing meningitis. Here are some other skull fractures that they talk about. The Lefort fractures. Take a look at this in your book and see what they suggest to know for the exam. I didn't remember any of these on my exam, I don't think, but they're on there. They're testable subjects. They're more trauma, ICU-based questions. But you have different degrees of the Lefort fracture. You could kind of see it's all along those suture lines. Okay, now seizures. So I identified in this presentation just the 4 main types of seizures that you could potentially see on the exam. There's lots of types of seizures. If you Google and search seizure disorders, there's all sorts of different classifications for them. So the first one that I go through is the most commonly well known, the grand mal seizure, tonic-clonic seizure. And there's 3 phases to it. There's the tonic and clonic phase, and then there's the postictal, which accompanies most seizures. So we'll go through each one. That first phase is where typically you see a sudden loss of consciousness. And the skeletal muscles will suddenly tense because you're starting to get a wave of improper electrical activity across your brain. So you'll see a sudden tensing up in this first phase. The eyes will usually roll or deviate upwards, and you can see either the mouth open wide, it's called an ictal, or you'll see it clench. And because they're not breathing typically, they're so tense, their skin will turn blue or slightly purple, and they're not swallowing properly, so there's a pooling of saliva. They'll have an elevated blood pressure just because of everything so tense, and they're releasing epinephrine as a compensatory mechanism to this change. You can see dilated pupils at times. Again, that epinephrine, that sympathetic response, increased heart rate, sympathetic response. And so after you have that sudden tensing of that wave of electrical activity, then those waves will start to change and decrease in amplitude. And so that changing, that fluctuation and change, is when you start to see muscle relaxation superimposed over that muscle contraction. So you'll see it relax, and then the electrical activity will come back, and so you see the contraction. That's when you start to see the seizure that we're commonly aware of the shaking. So that's something that, because seizures are something that you don't see often enough, at least I haven't, to not create a visceral response in someone who sees it. Right? It's something that's jarring, so physical and sudden, that it's important to remember, okay, this is a physiologic response of the body, of the muscles at least. And so if someone's in the room, like a family member, again, there are going to be a lot of questions on how do you talk to the family, how do you educate, how do you calm a situation. And if they could give you a question on your patient's having a seizure, and it's not necessarily what do you do for the seizure, it's how do you talk with the family. It could be as simple as treating the patient first, obviously, but explaining what's happening. So the frequency will start high and then slowly become low to the point where the amplitude starts to level back out. And so you'll see this clonic phase is usually a lot longer than the tonic phase, which is why we don't always see a long tensing phase. We usually see the actual shaking phase, the clonic phase. And then after they've exhausted this, or we've intervened in the seizure, and we'll go through the medications to intervene the seizure, they'll talk about a post-ictal phase. And not a lot of studies have been done to exhaust how this phase occurs, but what is theorized is that because the normal cerebral auto-regulation of impulses and glucose has been changed, that it takes time for then that glucose to be reprioritized back to the normal state. And the same applies for perfusion. So once the body's blood pressure comes back down and everything starts to be switched back to a normal regulatory state, then you'll start to see them slowly come out of that post-ictal state. So they can have some stertorous breathing, like snoring-like breathing, but usually very tired afterwards. And they think it's because of how much sugar is used in that aggressive seizure. The other types of seizures that you may see a question about, not necessarily, is the myoclonic. So these are more non-regular twitching. In a seizure, you'll see rhythmic twitching, the violent shaking. It almost has a pattern to it, whereas this, you can see some non-regular twitching. They have shown this in Alzheimer's and Parkinson's patients where they'll have twitching, but it's not regular. It'd be, let's say a 1-2 twitch, a pause, then a 1 twitch, then a pause, then 1-2 twitch. It could be arrhythmic twitching. Absence seizures are more common in children, and it's this sudden state of impaired consciousness, so the sudden blank stare, but they won't have the tonic and clonic phase of seizures. And then the atonic is a sudden loss of upper musculature, specifically the trunk, and it's very short lasting. So children could just fall down, and maybe they'll have one of those ictal cries, and then be able to regain their muscles and continue to move. So there's lots of different types of seizures. Know the primary ones, and we'll go into how to prevent and also intervene in a seizure. So we'll commonly use Ativan and a 0.05 to 0.15 milligram per kilogram, so weight-based for all of this. And Valium's slightly higher as far as milligrams go. So a quick way to do the math on that is multiply the weight by 10 and then divide it by 100, right, for Ativan. Because if you look here, the middle road, which is if you don't know anything about the patient, right, you don't want to overdose them, but you also don't want to underdose and not break the seizure. That middle road as far as dosing is 0.10. So if you multiply their weight by 10, let's say in kilograms, my weight in kilograms is about 70, so it's 700 divided by 100 would be 7. So you'd give me 7 milligrams of Ativan, roughly. Now, if you knew I was very sensitive or if I was very responsive to benzos, then you would definitely do a lower dose. Or if you knew I had a seizure disorder, you could potentially have to use more. Things to use to prevent seizures are Dilantin, and sometimes they'll use phenobarb as well. Not all hospitals use phenobarb in their protocols, but many do. And for the final thing we'll talk about today is meningitis. So I'll start with the normal CSF overview. It's interesting in that CSF, if we remember, is made by the choroid plexus. It has water, electrolytes, neurotransmitters, glucose, and protein naturally in that fluid, and it's filtered in the arachnoid space and taken up by the sagittal sinus to be brought back to the heart. And if you were to check the sugar of a cerebrospinal fluid, it should be roughly 60% of their current blood sugar. So if you were to take a CSF sample and a blood sugar at the same time, measure the glucose of the blood and the CSF. The CSF should be roughly 60% of that blood sugar from the blood. A normal protein value of CSF is between 20 and 45, and then a normal opening pressure, if measured in water, is between 80 and 180. So we use these as comparisons to different types of meningitis, bacterial and viral. Now, you could think about these very, very logically, just what happens, what does bacteria do differently than a virus? In bacteria, it's made up of proteins. The cells that are used to destroy bacteria are made up of proteins. So when we start to see bacterial meningitis and we do a lumbar puncture and we examine that fluid, we see a lot of bacterial and cell debris. So we'll see a lot of extra proteins within that CSF. Versus viral, we should see moderately elevated proteins because we're still using a type of white blood cell to attack and respond to a virus, but they're different and not as much as the ones used to attack bacteria. Now, when we look at glucose, the difference between bacteria and viruses is that bacteria utilize glucose. So we should see lower than 60% of our serum glucose in a bacterial meningitis, whereas viruses don't use it at all. Same thing for bacteria. We use a lot more white blood cells to respond to bacteria than we do viruses. And because we have a lot of that slough, that bacterial and white blood cell debris, we should see our CSF being a lot more purulent or cloudy white than that of a normal clear CSF. And so the same thing is true with viral. We shouldn't see a lot of that debris. It should be clear in viral meningitis. And then in bacterial meningitis, because they are larger in size, bacteria, and because they make a lot more debris, we should see a higher opening pressure than we would a viral meningitis. So when we're trying to examine if a patient has meningitis or not, we can use a lot of confirmation through mechanical means. So we can confirm or potentially guide our diagnoses towards that by using physical tests of the spinal cord and pain response. So naturally, if you look on the right, the spinal cord is connected to your brain, and it's tethered down at the bottom of your tailbone. So what you end up seeing is when you tilt your head forward to position your chin to your chest, that spinal cord must travel with your skull. So because you're lengthening that distance slightly, your spinal cord is stretched. Because it's tethered to the bottom, down near your tailbone, the only thing that's allowed, the spinal cord is allowed to do is stretch. And the same can be said when stretching your hip and knee. We'll look at that in a different test. So when we're checking for nuchal rigidity, which is neck stiffness and pain, we're gonna check to see, is the spinal column inflamed from potential meningitis response? And by us pushing the patient's head forward down to their chin, we can see that by stretching that inflamed spinal cord, all those neuronal structures, especially within the meninges, it's going to elicit a pain signal and stiffness from the muscles surrounding the neck to try to keep that distance between the spinal cord as short as possible. Because if you're stretching an inflamed structure, it's going to signal a lot of pain. So that's what we see in nuchal rigidity is when we bend the chin down, we're effectively stretching an inflamed, angry structure that signals a pain response. So if your patient yells out or winces, or if it's hard to tilt their chin forward, it could indicate that the spinal cord's inflamed. And so we can do this as well to see, if we're not sure about the nuchal rigidity, we can check this with a Koenig sign by checking the sciatic nerve pain. So we could do the opposite. We can stretch from the bottom of the spinal cord by stretching the hip and knee forward. That's what is going to happen there is the femoral nerve and the sciatic nerve are attached to different positions within the hip. So once we stretch those nerves down and we pull the spinal cord down, we should see a different type of pain in an inflamed spinal cord. So this is something that's easier explained or seen than it is explained, I should say. So on the left here, you've got your Koenig sign where you're stretching the hip and you're extending the leg, which is pulling the nerves of the spinal cord down. And you start to see either resistance of the muscles trying to stop that, or you see pain in the sciatic nerve. Another reflexive response you can see in meningitis is the Brudzinski sign. So this is when you flex the chin forward, so you're extending the spinal cord. The body compensates by bringing the knees forward or bringing the knees up and the feet back. So that's going to effectively shorten the spinal cord from the bottom. The body's trying to maintain as short of a spinal cord as possible, and because we've lengthened it by putting the chin to the chest, the body's going to respond is to draw the knees up. So this may be obvious in one of your patients with meningitis. They may be trying to draw their knees up, and you might think, oh, they've got a pillow under their knees, and their head is flexed backwards, and they're wincing because it's painful. And you can see them trying to shorten their spinal column reflexively as much as possible just by examining them. You don't even have to touch the patient. So meningitis depicts itself a lot in just physical responses outside of what you could just determine from a lumbar puncture. So I know that's a lot. There's a few things I didn't cover that are definitely in the exam booklet for neuro. Some of those being brain death testing all those different cranial nerves. Guillain-Barré syndrome. You've probably heard or seen that at least once in your career if you're taking this. Myasthenia gravis and muscular dystrophy are smaller topics, usually just half a page in a test booklet that they want you to just know the basics about. So spend an hour, 2 hours reviewing those. Again, I always say spend the time that you'd likely see of the likelihood you'd see the content. So spend more time on strokes, spend more, but give yourself time to know broadly what these smaller topics do. All right, so we'll do a few clinical questions. Which of the following about pupillary response is true? A, pupillary change is the first sign of an increased ICP. B, sympathetic stimulation produces dilation of the pupil. C, the optic nerve is solely responsible for pupil size. D, bilateral dilation of the pupil is an early sign of increased ICP. So in these kinds of questions, they're really asking you to pull back from your neuroanatomy and to know what a change in pressure would cause. So when we look at this question, we're really thinking about what does sympathetic stimulation do, what does parasympathetic stimulation do, and what would a change in pressure end up causing. So for this question, we know that sympathetic stimulation causes a dilation of the pupil, right? Fight or flight, epinephrine. Whereas parasympathetic causes constriction. So when we have an increased ICP and it starts causing pressure inwardly to structures, then we'll end up seeing a change in level of consciousness first, because those consciousness centers are higher. And then as that pushes laterally, we'll start to see a loss of parasympathetic stimulation, which is constriction, resulting in subsequent observation of just the sympathetic stimulation, which is dilation. And remember, this could be different in epidural bleeds, and where you'd see a change in pupillary size first. So remember, if they're asking about different types of bleeds, just be aware of what would potentially happen first. Okay, number 2, a 32-year-old male is admitted with raccoon eyes and notable clear fluid draining from his nose. What is the most appropriate response or intervention? Roll and tape gauze under his nose. Prep the patient for surgical repair. Pack the nose with sterile gauze. Or insert an NG tube and set it to low intermittent suction to prevent any kind of vomiting. Right, so this is a question that's trying to determine if you're aware of what problem this is, and then it's asking you to produce the safe intervention, the appropriate intervention for what the problem is. So here we've got a basilar skull fracture, right? That meningeal blood is pooled at the eyes, and the CSF is draining from his nose. So with the basilar skull fracture, we know that we can't necessarily surgically repair that. And we know packing or inserting anything into the nose could potentially cause meningitis. So we just want to roll and tape gauze under his nose. And again, they're going to ask a lot of questions on education, patient interaction, family education. So this may not only be a what is the right intervention, but it's what do you teach the patient? So they could say, as one of the answers, of educate the patient not to blow their nose. So that's why there's such a large part of this exam is focused on patient interaction. It's because you're not just doing things to people, you're doing things with people and educating them and teaching them how to best take care of themselves as well. 3, a John Doe presents with a scalp laceration and a depressed skull fracture of 6.2 millimeters. So which of the following is true regarding the care of this patient? The wound should be sewn shut. and close observation should take place to watch for changes in neurostatus. B, you should prep the patient for surgical repair. C, pack the nose with sterile gauze. Or D, insert an NG and set it to LIS, again, to prevent vomiting. So this question may be more obvious, but with the exam, 150 questions, it might get fatiguing at the end, test fatiguing, and you may forget about how much a depressed skull fracture should be before it's repaired. So we should be thinking of closer or anything above 5. So you need to prep this patient for surgical repair. Upon examination of a patient with bacterial meningitis in their CSF, it will reveal the following, except for what? A, cloudiness. B, decreased glucose. C, decreased protein. Or D, increased opening pressure. So this is one of those questions that even if you didn't know anything about bacterial meningitis, you could potentially still answer correctly, right? If you know how bacteria differ from viruses, then you could piece this question together and potentially get the right answer, right? You know that bacteria eats glucose and utilizes glucose, so that one would indicate a correct answer. Cloudiness, you know that bacteria is a larger structure than a virus, and when broken down has a lot of contents that's released from within the bacteria. So cloudiness would make sense. D, you know that a lot bacteria, because again it's a larger structure, would cause more pressure on the cerebrospinal fluid, and so that would hint at you to pick C. And those are all the questions I have for you. There are a lot of questions in your study book, and hopefully you bought one of the practice exam booklets to help review even more. So really focus on that rationale for those questions, because that's what's going to really smooth out any of the knowledge that you've picked up. And in the next lesson, we'll talk about respiratory.